Welcome to the deep dive. Ever wondered about that persistently watery eye, maybe in a newborn, you
Uh,
know, or even experienced it yourself?
yeah, it's surprisingly common.
It is. So today we're diving into nasolacrimal duct obstruction. You can think of it as a tiny plumbing issue, really, for your tears.
A good analogy.
We've sifted through the essential knowledge, the key studies, to bring you a clear picture of what it is, why it happens, and importantly, what can be done about it.
That's right. Our goal here is to give you the need-to-know info kind of quickly and without getting lost in all the medical jargon.
Exactly. A focused look to pull out the crucial points. We'll cover everything from, the basic definition right through to the long-term outlook.
Aiming for a solid understanding that hopefully sticks with you.
Okay, so let's kick things off. To get us started, what exactly is nasolacrimal duct obstruction in, plain English?
Simply put, it's when the tear duct, that's the small passage draining tears from your eye down into your nose, gets blocked or maybe just narrowed.
Okay, blocked or narrowed.
Yeah. And the main result is that tears just can't flow away normally, so you get that watery eye.
Right.
You might also see some discharge, and unfortunately, it can sometimes lead to eye infections, too.
Like a blocked sink, you said. The water just backs up.
Precisely. That's a really good way to think about it.
And where in this sort of drain pipe system does the blockage usually happen? Is there a common spot?
Yes, most commonly, the blockage occurs right at the far end of the tear duct, the part that actually opens into the nasal cavity.
Ah, okay, so right near the exit point.
Exactly. Imagine the blockage right there near the end of that tiny drain.
Got it. Now, what are the different ways this blockage can occur? Is it always something you're born with, or can it develop later on?
Both are possible, actually. We talk about congenital obstruction, which means it's present right from birth. And this is pretty common in newborns.
Okay, congenital.
Then there are acquired causes. These develop later in life. And they can include things like inflammation in the tear duct area, maybe an injury to the face or nose, or even structural issues inside the nose that might press on the duct.
Interesting. So, are there specific things that might make someone more likely to get this blockage? What are the risk factors we should know about?
Yes, definitely. Several factors can increase the risk. For newborns, congenital abnormalities are a primary risk, basically. The tear duct just didn't quite finish developing properly before birth.
Makes sense.
Eye infections or trauma, like a knock to the eye area, can also play a role.
Okay.
And interestingly, chronic nasal and sinus problems can contribute too, probably because the inflammation spills over, affecting the tear duct.
Oh, that connection makes sense.
Older age is also a risk factor. It's likely these tiny ducts can just naturally narrow a bit over time.
Right. Wear and tear almost.
Sort of. And finally, having a family history of this condition might slightly increase your chances as well.
Okay. So, we have this blockage. What happens next? What's the chain of events in the body, the pathophysiology that leads to the symptoms we see?
Well, the direct consequence is simple. Tears can't drain properly, so they back up.
Right.
This leads to a buildup of tears on the eye's surface, and you also get increased pressure within that little tear drainage system.
And that causes the symptoms.
Exactly. The visible signs are the overflowing tears, Epiphora, technically, and the eye discharge, which can sometimes be quite thick and sticky.
Lucky eyes, yeah.
And, crucially, a greater chance of infection because those stagnant tears can become a breeding ground for bacteria.
Right. That makes sense.
Yeah.
Now, if someone comes in with a watery eye and that discharge, how do doctors figure out if it's definitely a blocked tear duct and not something else? What are the main differentials?
That's a critical question, absolutely. Several conditions can look quite similar. In newborns, one important differential is something called congenital dacryocystitis.
Dacryocystitis. Okay.
Yeah, a key sign there is often a tense sort of bluish swelling you can sometimes feel under the skin, right at the inner corner of the eye.
Okay.
We also need to think about conjunctivitis, either congenital, meaning present at birth, or other types that develop later.
Pink eye, basically.
Exactly. And also, a scratch on the eye surface, a corneal abrasion, can cause tearing and discomfort too.
Are there any more serious conditions that need ruling out urgently?
Yes, absolutely vital. The big one to consider, especially in infants, is congenital glaucoma. This is serious and needs urgent attention.
Okay, glaucoma. What are the warning signs there?
There's a helpful mnemonic: cloudy big light, think. Cloudy cornea, the front part of the eye looks hazy. Big eye, one eye might look noticeably larger than the other. And sensitivity to light photophobia.
Cloudy big light. Got it. So if you see those signs.
Immediate evaluation is needed, definitely. The notes also mention some rarer congenital conditions like albinism and aniridia, which sometimes have associated tear drainage issues, but glaucoma is the key one to rule out urgently.
That really helps clarify things. Now let's talk numbers. How common is this nasolacrimal duct obstruction? What's the epidemiology look like?
Well, the prevalence does vary a bit across different populations and age groups, but for congenital obstruction in newborns, it's estimated to affect a pretty significant chunk, somewhere between 5% and perhaps up to 20%.
Wow, that's quite high.
It is. Interestingly, it also seems to be slightly more common in girls than boys.
Oh, really? Any reason why?
The reason for the sex difference isn't entirely clear, but it's an observed pattern. The encouraging news, though, especially for parents, is that in many, many infants, it resolves completely on its own,
Oh, good.
often within the first year of life.
That's reassuring. So what are the typical ways this condition shows up? What are the clinical features someone might notice?
Okay, so across all ages, the common signs include that excessive tearing, persistent eye discharge, often described as thick, sticky, maybe yellowish, recurring eye infections like conjunctivitis, redness of the eye itself, and crusting of the eyelids, especially noticeable when waking up in the morning.
Right, the eyelids stuck together.
Exactly. In infants, specifically, in addition to those, you might notice just constantly watery or tear-filled eyes, even when they're not crying.
Yeah.
Sometimes maceration, which is like a softening or irritation of the skin around the eyelids from being constantly wet.
Yeah.
And of course, those sticky eyes and local infections we mentioned.
Okay. So if these symptoms are present, what kind of tests or investigations might a doctor actually perform to confirm things?
Well, the cornerstone is really a thorough eye examination. That includes a careful look at how the tears seem to be draining or not draining, as the case may be.
Just by looking.
Often, yes, the clinical picture is quite suggestive, but one specific test that might be used is the fluorescein dye disappearance test.
Fluorescein dye, how does that work?
It sounds fancy, but it's quite simple. They place a tiny drop of harmless fluorescent orange dye in each eye. Normally, this dye should mix with the tears and disappear down the tear ducts within about 5 minutes.
Right.
If there's a blockage, the dye will just hang around on the eye surface for much longer. You'll clearly see it pooling there.
Ah, I see.
And sometimes, using a special blue light, the doctor might even be able to see if any dye has managed to make its way into the nostril, which would suggest the duct is at least partially open.
Interesting. But you said often the diagnosis is just clinical.
Yeah, quite often, especially in classic infant cases, the history and the examination findings are enough, and the dye test isn't strictly necessary.
Got it. So let's talk management. What can actually be done to treat a blocked tear duct? What are the options?
Right, the management strategy often depends on the patient's age, especially whether it's an infant or older.
Okay. Let's start with infants.
For infants, the initial approach is usually conservative, very non-invasive. Parents are often taught how to do gentle lacrimal duct massage.
Massage, how does that help?
It involves applying gentle pressure and downward stroking motions along the path of the tear duct, usually several times a day. The idea is to put a little hydrostatic pressure on the fluid column to help pop open that membrane at the bottom end.
Okay, gentle pressure.
Yeah, gentle is key. Warm compresses applied to the area can also be soothing and might help loosen any discharge.
And what if there's an infection?
If an infection like conjunctivitis is present, then antibiotic eye drops or ointment will definitely be prescribed to clear that up.
Right.
But often it's just the massage and keeping the eye clean.
And what if that doesn't work? If it persists?
If the problem continues, usually beyond about a year old, then a minor surgical procedure called probing might be considered.
Probing.
This is typically done under a brief general anesthetic as a day case.
And what about for older children or adults? Or just general advice?
Well, for them, and also as a general supportive measure even for infants alongside massage, regular cleaning of any discharge from the eyelids is really important, just using cooled boiled water and a clean cotton ball.
Okay, basic hygiene.
Exactly. And again, topical antibiotics are used if there's an associated conjunctivitis. It's really worth remembering that stat about spontaneous resolution in infants aged 6 to 10 months.
Yes.
Over half will get better on their own with just these conservative measures. So patience is often key initially.
That's a really important point. Over half resolve spontaneously. But you mentioned probing if it doesn't resolve. Can you tell us a bit more about that?
Sure. So probing is typically recommended for that persistent obstruction in infants after they turn, say, 1 year old, maybe a bit earlier or later, depending on severity.
Right.
As I said, it's usually a quick outpatient procedure under light general anesthesia. A very fine, smooth probe is gently inserted through the tear duct's natural opening in the eyelid corner
Okay.
and passed down through the duct into the nose to try and physically clear that blockage, often a thin membrane.
And is it usually successful?
It has a pretty high success rate, actually, especially for the first attempt. If the blockage persists or comes back after the initial probing, the procedure might be repeated.
Okay.
And sometimes, during a repeat probing, a tiny flexible silicone stent or tube might be placed temporarily within the duct to keep it open while it heals. That usually stays in for a few weeks or
A
months.
stent. Right.
Okay.
And are there other surgeries?
In less common cases, particularly in adults with acquired obstruction, or if probing hasn't worked in children, a more involved surgery called dacryocystitis, or DCR, might be needed.
DCR. What does that do?
That basically creates a whole new drainage pathway for the tears, bypassing the blocked lower part of the duct and going directly from the tear sac into the nose. It's more complex.
I see. And you mentioned age limits.
Yes, it's important to note that surgical intervention like probing is very rarely considered before an infant is at least 6 months old, largely because of that high rate of spontaneous resolution we talked about. You want to give it time to sort itself out first.
That makes perfect sense. So overall, what's the long-term outlook for someone with this condition? What's the prognosis like?
Generally, the prognosis is very good, actually. Favorable.
That's good news.
Especially in infants, as we've stressed. It often resolves naturally within that first year, or responds very well to massage or probing if needed.
And for adults?
For adults, the success really depends more on the underlying cause of the blockage and the specific management strategy used, like whether it's inflammation, trauma, etc., and whether DCR surgery is needed. But generally, with appropriate care, most people do achieve significant improvement or resolution.
Okay, good. Are there any potential problems or complications that can arise from having a blocked tear duct, or maybe from the treatments?
Yes, there are a few potential complications. The main ones from the condition itself are recurrent eye infections, like conjunctivitis or even dacryocystitis, which is an infection of the tear sac itself.
Ooh, right.
That chronic tearing, which can just be socially awkward and irritating, general discomfort, and sometimes even irritation of the cornea, the front of the eye, from being constantly wet or wiped.
Yeah, I can imagine that's annoying.
If chronic infections are left untreated, there is a risk, though small, of more serious issues, like infection spreading. And regarding the probing procedure specifically, while it's generally very safe, potential risks include failure. It just doesn't open the duct, or, very rarely, creating a false passage with the probe, or maybe some minor bleeding or temporary scarring, but complications are uncommon.
Okay, so mostly manageable risks. This has been a really helpful and, I think, very clear explanation.
Glad to hear it.
So, just to recap the key takeaways. Nasolacrimal duct obstruction is common, especially in babies, often gets better on its own in that first year.
Definitely.
But if not, there are various ways to manage it, starting with simple things like massage and cleaning, moving up to surgical probing if necessary.
Exactly. And the important thing is, if you do have any concerns about a persistently watery eye, whether it's in yourself or your child, it's always best to get it checked out by a healthcare professional.
Yes.
They can give you a proper diagnosis and talk through the best guidance for your specific situation.
It's absolutely crucial advice. And for our listeners looking for more resources to support their learning and revision on medical topics like this, don't forget to check out PassTheMSRA.com and also FreeMSRA.com.
Great resources.
Definitely. Now, for a final thought to leave you with, given how common this is in newborns and the fact that most cases do resolve spontaneously, what future research do you think could really make a difference in maybe identifying those infants who are less likely to get better on their own, potentially paving the way for earlier, more targeted interventions for those specific cases?
That's a fascinating question. Perhaps genetic markers or maybe subtle anatomical differences detectable earlier? Definitely something to ponder.
Something to consider. Until our next deep dive.